orthopedic surgeons, sometime in our life, we have seen injuries like this. And when you see injuries like this, maybe in residency, in medical colleges, in big institutes where such trauma happens, what is it that comes to our mind? Or if we see something like this, okay, the American Academy has predicted that by 2030, the US will be looking at 30,000 revisions a year. Also, there is a flurry of ACLs happening in the country, and with ACLs, primary ACLs, we are seeing an increase in the revision ACLs which are happening, and then re-revision ACLs. So we are looking at a lot of these bone losses, a lot of these bones where there is no bridge. What does the orthopedic surgeon do? So God has made two important bones for orthopedic surgeons. One is the pelvis bone, where we can take grafts, and the other is the fibula, where we can take the other autograft from. But the problem is that there is donor site morbidity, and there is always limited supply of the native bone. So how do we bridge the gap? And this gentleman also had the same question. This is Jacob van Merkeren. He's from Netherlands, and he was a surgeon, and a soldier came to him and said that he has a defect in his skull due to one of the wars. How does he fix that defect? So he did not have anything with him, but he had a dog skull with him. So he took a piece of that dog skull bone and fixed it there. This was year 1668. The soldier went back to the community. The church came to know that he has a dog bone in his skull, and he was outcasted. He was said that you are not allowed to enter the church. This gentleman, this soldier, went back to the surgeon and said that I want this bone removed because they have thrown me out of the church. They tried to remove that bone piece from his skull, and they could not do it because it was so well integrated with his native skull. So this was the first recorded bone banking procedure in history, in modern history. The first actual modern bone bank came in the year 1949 in the US. And this is also because of a war, because there was a lot of injuries in World War II with a lot of non-unions that was happening, and then there was big bone defects. And the Naval Medical Center planned that they needed some form of bone to fill that gap, right? By this time, in 1949, the refrigeration technology had advanced, and they could actually keep the bones preserved for a longer duration of time. India has also been one of the early movers in the bone bank. In 1988, Tata Memorial Hospital introduced the first bone bank in India. And because it was a cancer center, they had to use a lot of those bone for their patients who had a lot of defects and reconstructive surgeries in the cancer. So, taking the cue, we at Shelby Hospitals also have started a bone bank. And the reason why we started a bone bank was because we are already doing about 10,000, more than 10,000 joint replacements at the group level. And a lot of this bone that was generated from TKRs and THRs was actually going waste. It was biomedical waste. And this precious bone was actually useful for a person who has a non-union, for a person who has a defect, for a person who needs this bone for good use. So the whole idea started that why don't we utilize all this biomedical waste that we have and put it to good use. And thus we started the first bone bank of Gujarat last year. So what we do here is basically we collect all those residues of the bones that we generate in the operating theatre, and that is taken to the bone bank, which is in the hospital premises, and it is processed, it is cleaned, it is irradiated, and then it is stored by freeze drying or freezing. And this is how the final product looks like, you know. So we have an option of using corticocancellous chips, option of using bone blocks, option of using demineralized bone, option of using freeze-dried bone. And if any time in the future you're looking at a revision or you have a big bone defect you can always remember the bone bank. Okay. So Let's go to the first slide that I showed you, right? This was the bone defect that we had seen on the first slide. This was a young man of 30 years from Rajasthan, okay, and this was the first injury that we had. For the primary procedure, we did not have any bone, so we tried to fix it with an external fixator, and we put in a cement in between, antibiotic loaded. After 3 months, there was another young patient who came and had a hip disarticulation due to RTA, and we preserved that femur for this patient. So donor bone allograft, so donor femoral allograft was coupled with a vascularized fibula, which was taken in the same patient, and then it was implanted in the first patient, in the primary patient. And this is the immediate post-op X-ray that we see. So the whole defect was bridged with the allograft as well as the vascularized fibula graft that we had. And this is 18 months post-op, what the patient is. The allograft tissue has actually united, fused completely with the native bone. And this is the result that we have at 18 months. So a person with no fibula is actually standing, walking and doing SLR without any problems. So thank you.